I'm so pleased to be here with you all today. I want to thank the sponsor and the program committee for inviting me, and I want to give special thanks to my colleagues in Olympia, Washington, who move the data back and forth. They are Peter Woodcox and Dorothy Lyons. They are the ones who do the heavy lifting. Some quick facts about births in Washington. In 2011, the number of births was 87,000. 3.1% of these occurred at home or in birthing centers. Like the United States overall, out-of-hospital births have been increasing in Washington state. From 2004 to 2011, the number of home births nearly doubled. The proportion of home births increased from 1.1% to 1.9% of total births. For births in freestanding birthing centers, from the year 2000 to 2011, the number also nearly doubled, and the proportion increased from 0.7% to 1.2%. Medicaid covers 50% of the total Washington births. Washington is one of about 11 states with Medicaid reimbursement for direct entry midwives. Wrong direction, I gather. This slide shows key milestones in the history of out-of-hospital births in Washington state over the past 30 years. In many ways, Washington is a model for varied birth settings. We have state laws, regulations, policies, and we have collaboration between midwives and physicians. In 1989, Washington faced a crisis in maternity care access. Midwives were welcomed to the ranks of prenatal care providers, but Medicaid did not at that time reimburse for home births attended by any provider type. Out-of-hospital birth remained a contentious issue throughout the 1990s. Our first reports met with sharp criticism. We developed an intent to treat analysis based on the premise that pregnant women who sought prenatal care from licensed midwives were planning or at least considering an out-of-hospital birth. We identified the licensure of providers who receive Medicaid payments for prenatal care, and we followed their patients whether they gave birth in an out-of-hospital setting or in the hospital. With a pilot project that required detailed reporting by midwives on each home birth, in 2001, the state Medicaid agency began reimbursing for planned home births. VBAC, multiple gestation, and breech births were excluded from reimbursement if they occurred in the home. The next three slides briefly describe our analytic methods. The cornerstone is individual record linkage of Medicaid claims and vital records, births, fetal deaths, and infant, child, and maternal deaths. We use the attendant at birth and birthplace type items from the birth certificate. From Medicaid claims, we identify prenatal care providers using procedure and diagnostic codes. In Washington, the birth certificate format is a little different. We have an additional category of licensed midwives in the birth attendant category. Nevertheless, in order to find the true specialty or licensure of all the birth attendants, we do an independent verification using licensure data provided by states in order to verify the credentials of the providers. This, in a state the size of Washington, this is a reasonably simple way to vastly improve the quality of data about birth attendants. We classified providers of out-of-hospital births based on the typical location where their deliveries occurred. We created three mutually exclusive categories. Home birth providers had at least 75% home births. birth center providers had at least 75% birthing center births. And of course, we were left with a category that did not fit neatly into home or birthing center. And we called those providers mixed, since they delivered babies both in the home setting and in birthing center settings. This slide shows the numbers of providers by licensure for these three categories. And I'd like to add that in 2011, there were 1,674 home births and 1,006 birthing center births in Washington. We identified prenatal care providers for Medicaid women and assigned them, the women who gave birth, to one of 6 groups. The last row on this slide shows the place where the birth actually occurred, which I will refer to as the achieved birthplace. The next to the last row shows the intent to treat groups. To be more specific, looking at the first group on the left-hand side of the slide, 598 women received prenatal care from a provider that we had identified as a home birth provider. This is the intent to treat group. Of these 598 women, 410, or 68%, achieved a home birth. So I'll present data for both the actual or achieved birthplace and the intent to treat groups. Looking a little more at the numbers for the home birth providers and the home birth deliveries, 188, or 32%, did not give birth at home, and this percentage approximates a transfer rate. Expenditure data were computed for both the achieved birthplace groups and for the intent to treat groups. And I will start with the achieved birthplace type, since this is a little easier to follow. We measured Medicaid expenditures from all Medicaid claims from 270 days prior to delivery through the second postpartum month. This slide shows average Medicaid expenditures for low-risk women who gave birth in the stated locations. The all planned out-of-hospital group is the sum of the home births and birth center births groups. After all the discussion yesterday, I certainly want to tell you a little bit about how we defined low risk. We used only criteria from the birth certificate. We identified low-risk births as those that were delivered at term, 37 to 41 weeks, singleton births only. There was no indication of risk factors in this pregnancy from the checkboxes on the birth certificate. That would be diabetes, hypertension, previous poor outcomes, birth defects, chorioamnionitis, cerclage, or trocholysis. And we included a few other select conditions that represented higher risk births. What is remarkable to me about this slide is that despite the very small denominators, the expenditures for the out-of-hospital birth groups are actually quite consistent and consistently lower than those for in-hospital births. We struggle to find appropriate comparison groups. Since no C-sections occur at home or in birthing centers as achieved birthplace types, we thought the appropriate comparison group was vaginal deliveries in the hospital. But we've also compared the expenditures for hospital C-section deliveries as well. These are fee-for-service data only. Washington has a large managed care component to their Medicaid program. This type of analysis does not work in the managed care data because essentially all the expenditures are leveled. So here are the same groups without the restriction to low-risk births. What is remarkable here is how similar the pattern is, and actually how small the added expenditure is when all births are included. So for the hospital vaginal deliveries, the average expenditure was, for the low-risk group, was $5,603. For the hospital C-section deliveries, the low-risk average expenditure was $6,858. Very small incremental differences, but a very consistent pattern. So for the intent to treat analysis, we have changed the comparison groups. At the same time, we recorded the specialty of out-of-hospital providers. We also tracked CNMs who delivered primarily in hospitals. So for this analysis, it seemed that a better comparison group than all hospital deliveries was hospital deliveries where the woman received prenatal care from a certified nurse midwife. Because this is an intent to treat analysis, any provider of any specialty or licensure might have delivered these babies, and C-sections occur in all of these groups. The direct cost for C-sections will be included in the overall expenditures, and we'll look at the C-section rates for these groups in just a minute. We use the same definition of low risk as in the previous group of slides. And actually, remarkably enough, the savings are quite comparable. Removing the restriction to low-risk births, we see a little bit of a change in the pattern. Again, overall, there's not a great increase in the average Medicaid expenditures. For the hospital CNM cases, the expenditure increased from $5,412 to $5,837. For the hospital other group, the average expenditure increased from $5,792 to $6,039. For the birth center births, we actually see exactly the same proportion of savings as in the low-risk group, a 33% reduction in overall expenditures. For the planned home births group, there is attenuation of the savings for reasons that are not known to me, though I have some hypotheses about that. Here are the C-section rates for these groups. So the first comparison group on the left is all hospital births overall, 27.9%. This is total C-section rates. We see dramatically reduced C-section rates for all of the out-of-hospital groups. Again, this is an intent to treat analysis, so these are the women in the home birth group, the birth center group, the mixed, and the all out-of-hospital group, which combines the other three. These are women who we identified as seeking prenatal care from a provider of home birth or birthing center births, and we followed them through to the time of their delivery. And of course, there were numerous transfers to hospital delivery care along the way, but the C-section rates are dramatically lower. It was also noteworthy that the C-section rate for births where the mom received prenatal care from a certified nurse midwife were also lower than the overall hospital C-section rates. I'd just like to add that the benefits of lower C-section rates are not limited to the reduced direct and immediate costs. This type of analysis does not address the question of what aspects of delivery account for the lower C-section rate. The other unanswered question is whether in some cases outcomes would have been better had cesarean delivery been performed. There are many limitations of the data that I have just presented, but there are also clear directions for making it better. And I'd just like to suggest that although the birth certificate has its limitations, there are reasonably feasible methods to improve the quality of data about birth attendance from the birth certificate. First of all, it would be wonderful if there were other states who could perform this type of analysis. The number of states that can do this at the present time, the data are there. There are other states that link Medicaid claims and vital records, and there are other states that have Medicaid reimbursement for midwives and out-of-hospital deliveries of various sorts. We would greatly value having larger denominators, the ends, more people in the sample so that we could address some of the power and statistical issues. It also might be possible to study different states' models of care and reimbursement and describe other insurance issues. There are many more sophisticated kinds of analysis that could be done with these data. We did not do any adjustment for risk factors other than the simple exclusion of high-risk women. And we only excluded a single outlier, and that was on the basis of infant medical care costs that were clearly outlier. Medical record review would greatly enhance the quality of an analysis, and even just more detailed analysis of the claims data that we had might permit identification of the timing of the transfer of care, which is a critical issue, and emergency transport expenses could be pulled out from the overall Medicaid expenditure data. My first recommendation, and we've actually done this, but my assignment today was not to discuss birth outcomes and infant medical care expenditures, so I'm not sharing that information with you, but I think that it's clearly advantageous to combine all of those studies for the populations where this might be expanded. That there are costs of poor birth outcomes that are not recorded in immediate and direct Medicaid expenditures. And so looking at birth outcomes in addition to expenditure data is critical to see a broader perspective. And I just, in terms of being fairly concrete here, well, I'd like to thank Caitlin Cross-Barnett for sharing the results of her survey data on the states where they have completed interviews about linkage of vital records to Medicaid claims data. The Medicaid Medical Directors Learning Network also performed a state survey earlier last year. The challenge that I faced was that the results didn't agree very well. And so I apologize to any state who may think that their status is misclassified here. Medicaid medical directors would say, yes, we link Medicaid claims and vital records. State registrars and directors of Centers for Health Statistics would say, no, we don't do it. So I made an educated guess when we had conflicting information, and I think the key here, and I don't claim to have perfect knowledge either about which states actually have Medicaid reimbursement for midwives, which is key because Medicaid isn't reimbursing. You're not going to get claims data for analysis of expenditures. But there are a number of states, Oregon, Washington, maybe California, South Carolina, and Florida, where it seems like data would be immediately available after the administrative hurdles of gaining possession of it for a specified project like this were surmounted. Thank you so much for your attention today.
Well, thank you for a very interesting talk, and a perfect segue to our next speaker, Kathleen Nolan, who is with the National Association of Medicaid Directors and who will provide a lot of discussion on what we've talked about so far in the session, and who hopefully has the answer to the data linkage issue.